I'm sorry for the frustration on getting set up. We're happy to have Doctors Without Walls here. And Maria, you're going to introduce your team. Thank you.
So I heard, welcome, and good morning, and thanks for having us. My name is Maria Long, and you may know me from my work with the warming centers. I am also now the executive director for Doctors Without Walls. We call them our guests at the warming center. We call them our neighbors without homes. We call them the houseless. We call them the working poor. And with Doctors Without Walls, we call them our patients. And there are many, and they cross over. Today we're here to talk to you about the work that we do on the streets, around 52 weeks of the year, around the clock, consistently. And we do that through our student volunteers who you're going to hear from today. We have 175 volunteers that are students, doctors, nurses, physician's assistants, pharmacists, dentists in some cases, who come out on a volunteer basis to make this work. Our organization was started as a formal 501c3 in 2009 by Dr. Mimi Doohan, who saw a need on the streets here after her travels around the world in helping underserved countries in Africa and such, but the need here was even greater. Our homeless population can vary in Santa Barbara County anywhere between 4,000 to 6,000 people across the county, depending on the count. And these are people who are in desperate need, who don't have health care. And we are here to fill in the gaps. We keep them out of emergency rooms, out of emergency services, therefore saving lives and saving money. Much like what we do at the warming centers, we save them through the night, but Doctors Without Walls, 52 weeks of the year, continually around the clock, will take care of our patients. And who I'd like to introduce you to is Zoe Teton and Andrew. And part of what we also do is we have two beneficiaries, not only our patients, but our students. We are teaching the next level of humanitarian leaders in medicine around the world. And Zoe has aspirations, and she's applying to medical school right now. She's not sure what genre she'll come in at. And Andrew, who you're going to hear from, is going to be a pediatrician. And so we also clearly work in times of disaster. We're always not also technical, so forgive us for that. But what we do best is exude kindness, give a helping hand, and make people feel better at their most vulnerable. And with that, I'd like to introduce Zoe, and she'll tell you a little bit about what we do, and then Andrew will wrap it up. And thanks again for having us. We're very appreciative. In times of disaster.
Yes, I would just like to mirror what Maria said and say thank you so much for having us. As a student, it's a really special opportunity to be able to not only volunteer with this organization and get all that exposure to medicine in the field, but to do things like this. So practice public speaking events and inform the general public about what we do. It's really exciting, and it's something I want to continue with throughout my career in medicine. So it's really special, so thank you. So to get started, I'm going to go over homelessness trends in the United States, nationwide, then kind of bring it into how that applies and is mirrored right here in Santa Barbara. And then Andrew's going to take over and talk about what we do specifically. So just to start off, a definition of homelessness, which is pretty difficult to actually define, but we generally go with the definition: lacks a fixed, regular, and adequate nighttime residence. Or who has a primary nighttime residence that is one of these three options. We focus on option C, which is a public or private place not designed for or ordinarily used as regular sleeping accommodations for human beings. The people we see generally are sleeping on the streets, on a friend's couch, in shelters, but never their own primary nighttime residence. So nationally, children actually make up almost 40% of the homeless population, which kind of surprises a lot of people. 42% of those children are under the age of 5. And that's actually one of the rising trends of homelessness, is we're seeing a lot more homeless families recently, which was kind of interesting. With the recession, A lot of people lost jobs. When you lose jobs, you lose health insurance in this country, right? Well, no, that's changing, but a lot of times that leads to homelessness for people. They get sick, they go to the hospital, they can't pay, all of a sudden their house is getting repossessed and they're living on the streets. It can happen that fast. So battered women, about 50% of homeless, or 50% of women that were surveyed attributed their homelessness to, fleeing from domestic partner violence. Then, it's kind of this vicious cycle. You're now on the streets, you're already a woman, a vulnerable population, now you're an even more vulnerable population. We refer to women on the streets as vulnerable populations within vulnerable populations, and we do extra help, or we give extra help specifically to women in our Women's Free Homeless Clinic, which is 3 Fridays out of the month. Andrew's going to talk about that a little bit more, but we just like to touch on that. Veterans make up 13%, which is extremely unfortunate given, the service to our country that they've done, and we try and, get them linked up at the VA when we find them in the parks, but a lot of times it's this barriers of access to care issue. It's hard for them to get out to the VA clinic, and if they have a grocery cart of belongings or a dog or, mental illness, which is our next trend. So yeah, 26% of the sheltered homeless are mentally ill. That's compared to 6% of the general population.
Is that percent?
Of 26% of the sheltered homeless are mentally ill. And usually that's another huge contributing factor to homelessness is that, they've been living with mental illness, either misdiagnosed or non-diagnosed their whole life. They then start self-medicating with substances or alcohol to quiet, voices in their head, which makes mental illness worse, of course. And you end up on the street in this, vicious cycle. And again, leading to addiction, which is difficult to measure because of this. We're not sure. It's hard to say whether addiction led to homelessness or as a result of homelessness got addicted. Either way, these are all very confounding factors. So we, in Santa Barbara County, every year we conduct something called the Common Ground, an amazing local organization. They conduct the Vulnerability Index, so we can see, how do our trends in homelessness compare with these national ones I just went over with you. So 60% of them either live on the street or in a shelter. 16 live in their car. And a lot of people say, if you're bringing these medical services to Santa Barbara and you're offering all of these, opportunities, doesn't that mean if you build it, they will come? More homeless people are going to come because we offer medical care. But when the truth is, when you ask people why they live here, it's usually the same reasons you or I are here. So they came for the climate, they came because their family lives here. A lot of people were living in Santa Barbara when they became homeless. Again, back to that issue of losing your job, losing health insurance, suddenly you're on the streets. So 35% of the people that were surveyed were left unanswered, and the vast majority of them were just already living in Santa Barbara. 68% men, again, 32% are women. Again, we'll get to the Women's Free Homeless Clinic. So 33% of adults living on the streets have reported some sort of physical or sexual abuse. 6% were currently pregnant. And of all those surveyed, they made up 732 emergency room visits, which is pretty staggering. It's an annual cost of over $4 million to our taxpayers and the hospital and services rendered. Because one of the main goals of street medicine teams is usually to reduce unnecessary emergency room visits. That's one of our goals, and I'm currently conducting a research project that aims to see, to what degree we're doing that. And so far, we've been collecting data for 6 months, just asking our patients during intake what they'd do if we weren't here. And of those surveyed, about almost 70 said they would go immediately to the emergency room. Of those 70, only 1 was actually referred to the emergency room. So of those, we did a really quick, rough estimate. If you say each emergency room visit is $1,200 on average in the U.S., that's an annual savings. That communicates to an annual savings of over $100,000 to our ER. So that was a big, exciting findings. So one issue that has been determined with the homeless population is this issue of tri-morbidity. Not only are they usually dealing with chronic medical illness, physical factors, they're usually dealing with some degree of mental illness and substance abuse. So we found that those, when they're struggling with those three things together, those are the population within the population that are most at risk. And it's been found that just being homeless is actually an independent risk factor for premature death. And in fact, the age of mortality among homeless is equivalent to that of third world and developing countries. And it's just pretty staggering. We're one of the most developed countries in the world, and yet we have this subset of the population that is dying at rates equivalent to third world countries. So this was a really interesting study that was done by Jim O'Connell. He's one of the absolute pioneers of street medicine. He operates out of Boston. He decided to do a cohort study. So for 6 years, in the early 2000s, he followed about 100 homeless individuals over time, and just saw where they were after 6 years. Out of that population, 30% were deceased by that end of the 6-year period. So that's, pretty staggering number. Of those still on streets, 15% were either in the streets, in the hospital, in respite care. He was the one who actually came up with this idea of the trimorbidity issue, that those that were most at risk had these three factors. Causes of death, cancer, pretty similar to what we see in the general population, but their health concerns are so unmitigated and not addressed. The one big difference was overdose. Substance has, especially in recent years, that's a trend that's actually changed. They did a similar cohort study in the early 90s, I believe, and one of the main causes of death at that time was AIDS. Now that's gone way down, and overdose on substances has gone way up. So that's actually one of the leading factors. So as a health organization, our big question is, how do we go from here, this man with a grocery cart full of everything he owns for his entire life, with severe mental illness and abusing substances to try and cope with that, and totally mistrustful of a system that has, kicked them while they're down their entire lives, basically. How do we go from that to providing them with health care? That was kind of our big question. And we drew the inspiration for the answer to that question from this man, Dr. Jim Withers, one of my personal idols. He operates out of Pittsburgh, and he started this concept of street medicine. He had the idea to gain access to this population and trust bridge with them by dressing up as a homeless individual and going out on the streets and saying, first just hanging out with them, getting to know them, and then starting to bring a backpack full of medical supplies. And once he made that trust, he was then, I'm a physician, if you need anything, I'm here, and saw patients right there on the streets. He kind of introduced this concept of meeting people where they're at, dealing with this super vulnerable population. You can't really expect them to show up at their 8 a.m. Doctor appointment and walk into the clinic and fill out the paperwork that asks for their address and their valid form of ID. But he introduced going to where the need is and meeting people where they're at. So it's pretty exciting, but we are one of over 90 worldwide street medicine teams, which actually is a pretty small number. This is a relatively new concept, but it's building a lot of momentum, and it's a very exciting time. So we're honored to be one of 90. And so how did it get its start here in St. Barbara? Maria touched on this a little bit, but our founder, Mimi Doohan, the second in that line, joined together with 4 other family physicians at the time and said, I really want to go to Africa and do all this humanitarian work and provide medical care, but, I have a family, I have a job here, I can't be just leaving. And then realized, we have a need right here in our backyard. And she sought, using Dr. Jim Withers as inspiration, sought to establish a team here. So they started out by doing totally backpack-based medicine. They did something called street rounds. So literally they would go out with a team and see patients wherever they happened to be at the time. We've now transitioned and we have 2 FIGS clinics as well, which Andrew will touch on. So our mission, which I'll just read, our mission is to provide free volunteer medical care for the most vulnerable of Santa Barbara, California, when and where they are in need, including in times of disaster, and to provide education and training for our volunteers and others in order to promote the excellent practice of humanitarian medicine in our hometown and elsewhere. So that's a big deal too. It's the most vulnerable of Santa Barbara. So it's not all of our patients aren't necessarily homeless. A lot of them are the working poor that maybe don't have really good insurance coverage or don't have insurance at all. I had a patient the other week who was this gentleman who came in to see us and was, very sad and sheepish because he said, I just lost my job and I can't afford the copay. He had insurance, but he couldn't afford the copay for just a normal office visit. And, he was living off of his wife's salary, and that was making him feel, very upset. But, we welcome anyone. So, just a little bit about us. We are a 501c3 nonprofit, and have been that way since 2009, as Maria mentioned. We really value transparency financially. Every year we publish an annual report, which tells you exactly where any fundraising dollars are going. The vast majority of our costs actually go directly into our services. So buying albuterol inhalers for our patients or prednisone and antibiotics. That all comes from volunteer donations. We treat the most vulnerable. We also provide, we're ready to go in times of disaster. So, we're totally accustomed to working out of backpacks, working in the park, doing street rounds, walking around and helping people. So we're kind of here as an organization for Santa Barbara. If anything were to happen, we can have a team assembled with full medical care, within the hour. So that's kind of a big deal too. And then education. Maria mentioned that we have 2